Okay, so just as a backdrop for this, for those of you who are not a part of the project team, we're talking today about the Improving Type 1 Diabetes Care Project, which is funded by the Helmsley Charitable Trust and involves Children's Mercy Hospital and the Joslin Diabetes Center and Cyft, CYFT. And we've got representatives from all of those organizations on the call today. This presentation is a presentation that we gave at the Advanced Technologies and Therapeutics and Diabetes Conference, ATTD, in Vienna, Austria in February. But I had a desire to share it on an internal venue so that some of our institutional stakeholders understand what we're doing, and then also to share it more broadly with the rest of the team who didn't get to actually see the presentation. So the goal of the project is, of course, to improve type 1 diabetes care by applying advanced machine learning and natural language processing and pairing those tools with quality improvement methodologies in clinic. If I can advance the slides. There we go. So just for everybody to know, these are my conflicts. So objectives are in about 20 minutes to talk about why we're considering machine learning in clinical care. We're in this project marrying it with quality improvement, and then what the implications are for learning health systems. I'm going to share with you a project roadmap. I'm going to share with you some of our initial work with our partners at Cyft to build predictive models, both at Children's Mercy and through our colleague Sanjeev Mehta's group at the Joslin Diabetes Center, and then what's next for the project. So we'll talk about glycemic control as an example of why we should consider machine learning and predictive analytics in clinical care. This curve, which is from a publication out of the Type 1 Diabetes Exchange in 2015, shows glycemic control across the lifespan. And a couple of things to point out about this curve. First, if you're 18 years or older, your target for hemoglobin A1C, which is just a biomarker that represents the average daily glucose over the prior 90 to 120 days with a lot of emphasis on the last 30 days. If you're 18 or older, your target is 7% or below. And so you can see 7% is down at the x-axis, and the median for the population at different ages is well above that. If you are below the age of 18, as of 2014 in the United States and around the rest of the world, your target for glycemic control is to have an A1C below 7.5%. And so again, you can see that we're not meeting that metric most of the time. And so one thing that's interesting here is that because of the insulin resistance that occurs during puberty and because of the disordered thinking, the lack of complete prefrontal cortex development in adolescents who are now taking charge of their diabetes care from their parents, we see a significant rise in A1C from about age 8 to about age 16, where it peaks between 16 and 18. And then it takes until about age 30 for that A1C to come back down. And there are a lot of folks who are interested in how to serve patients who we consider to be high risk. So a lot of people will define high risk as an individual who's got an A1C above 9 or 9.5%. And so you can see that really hits the very top of this hemoglobin A1C curve. And I think that we should not be defining high risk based on where you already are, but based on where we predict you're going to be. And so you can see, based on the red arrows here, that if we could identify a person whose A1C is down at 8 or 8.2%, but who's at risk for having a rapid rise, in their A1C, then maybe we would have a chance to, reduce the risk of this curve and in fact, shorten the curve. The other thing I'll point out is that if we look at the risk for lifetime complications, right, the higher your A1C is on average over time, the higher your risk for microvascular disease and macrovascular disease, so eye disease, kidney disease, heart attacks, stroke, and clearly you can see that the bulk of that risk in type 1 diabetes is concentrated during childhood and adolescence based on the glycemic curve. But secondly, we also know that the number needed to treat to prevent a complication in one person is much lower if you're trying to drop their A1C by 1%, say from 11 to 10, than from 8 to 7. So if I want to prevent one complication by dropping somebody's A1C by 1%, well, the number needed to treat if they're starting at 8% is in the hundreds, right? It might be like 1,200, and the number needed to treat if I'm dropping their A1C from 11 to 10 is actually more like 12. So there are several orders of magnitude difference in the health impact. We have the ability now to predict future trajectories of A1C in youth with type 1 diabetes using statistical models. So these data come from a publication by another registry, the German-Austrian DPV registry, and in this case they looked at longitudinal trajectories from age 8 to 19 for A1C, and they did what's called developmental growth curve analysis and latent class analysis, and so they identified these developmental growth curves or trajectories of hemoglobin A1C. So you can see there are some people, even though our overall mean is for people to rise during adolescence, there are actually some adolescents who have a very low A1C that is stable, and some that have a more intermediate A1C that is stable, and together they make up about 60% of the population. It's the other 40% of the population that are either always high or start low but have significant rises during their adolescence. And so this is important to know because I think that number one, the methods exist. Number two, it's important to know that these are heavily curated data that had to be collected and analyzed in a very systematic way across a large population to develop these models. So they require a lot of pre-work to develop them. So I'm going to apologize because a few of these slides have this blue box over them, and I don't know why it's happening, but it seems to only happen in WebEx. The question is, what can predictions bring to learning health systems? Well, we know that if we look at hemoglobin A1C across 8 developed nations, as shown here, if you look at the blue bars for each of these, you can see that the median A1C for each of these 8 developed nations is highly variable. And then if you look at the orange bars around each blue bar, you can see that the center-to-center variance within each nation is also very significant. So in the U.S., the median A1C by center varies from the proportion of people meeting their A1C target in this case varies from 15% to 28%, depending on which center you're at, so almost a twofold difference. And still, that's well below all the centers in Sweden whose proportions of people meeting their targets range from 45 to 55%. So we have a lot of intranation and international variation in people meeting their glycemic targets. So hence the need for learning health systems to try to improve these systematically. So what we have done in the past, right, the model on which I've built my career is that I decide to study something and assemble and analyze the data. I interpret the results, and then I go publish, and I hope that my colleagues in the field will read that work and will then learn from it and either teach the answer to the next important question or find a way to implement it in clinical care. And the average time to implement new discoveries in clinical care, at least in the drug world, can be as high as 17 years. So that's really too long. So in a learning health system, the goal is to decide to study something and then to take this all the way around the circle, and instead of going off and publishing and stopping there, the goal is to actually deliver a message back to the decision makers and the healthcare providers and to take an action to change practice immediately. And so really we're trying to hasten the pace of implementation of discovery. And so we're basing this work, of course, on the model for improvement, where we ask, what are we trying to accomplish? We ask ourselves, how will we know that a change is an improvement? And what changes can we make that will result in an improvement? And then we use plan, do, study, act cycles to try to implement and monitor that improvement and those interventions. So our goal in this work is to really design an integrated, data-driven care delivery system that will improve the care of families and persons with type 1 diabetes, but also to design a data-driven business intelligence system that will improve the fiscal health of diabetes centers who provide care for persons with type 1 diabetes. And you might be able to predict where this is going, right? So if this work has a cost to it, then the goal is to demonstrate that not only can we improve outcomes, but that implementing such a system could pay for itself, because we may be able to deliver more cost-effective care or improve our revenue capture with the same system that helps us to improve health outcomes. And ultimately, where we're headed is in a model that looks like this, that we want to think about all of our interventions in the clinical space as a toolbox of interventions for type 1 and, in fact, type 2 diabetes care. And so we start with, population monitoring and population health, and we try to enhance our phenotyping of the patient with enhanced health assessments using psychosocial screening and enhanced variables that we can deliver into the medical record. Mark Hoffman, who is on the call, has done a lot of innovative work with the Envirome, and now in our medical record at Children's Mercy, we actually have a tab for the Envirome, so we can think about some novel phenotypes. And then to apply near real-time risk stratification and actionable alerts, which in this case, involve identifying a cohort of individuals on whom we need to take action in near real time. And so you can see that if we have a toolbox of interventions, that some of them may be interventions that we think of traditionally in diabetes, like putting somebody on an insulin pump or exposing them to a continuous glucose monitor or hybrid closed loop artificial pancreas system. But there are others that I think are more behavioral in nature, and so they may involve peer mentoring or online peer communities. They may involve shared medical appointments. They may involve remote monitoring of some kind. And so as many unique interventions as we can glean from the literature can be placed into this toolbox. Then the question is, how do we best match the intervention to the need? So machine learning, simply improves our ability to use all of the available data to solve important problems. And I think that Len from Cyft has taught us that. We also know from others who think about data science that while we're surrounded by data every day, that the oceans of data only eventually lead to smaller rivers of information, small puddles of knowledge, and only the odd drop of wisdom. And so the goal is, how can we take this abundant data and all of the data and turn it into something useful and actionable in clinical care? So the traditional approach to identifying a population who are high risk for an outcome is to say, okay, what can I glean from the medical record simply by performing a Boolean search or a rules-based search? And the problem with this is that it doesn't rely on any predictions. It only allows us to review what has already happened. So the outcome has occurred, and now we want to go back and see whether we can undo what's been done. We can, of course, as I showed, use traditional statistical approaches to make risk predictions, but there are several potential problems with that if we want to apply it to real-time clinical care. The most important of which is that we have to make a lot of assumptions about what we think is important. The second of which is that we have to curate the data to a great degree. So, statistical models don't like to use messy, partly missing data. They like to use data that look similar across the entire population. And so it's a lot of work to run these and difficult to run them on messy data in real time. And so the interesting thing about machine learning, of course, and natural language processing is that we can apply these tools to make predictions using the dirty, messy, raw, partly missing, and partly reliable data that are characteristic of electronic health records. And in the example here, I gave the example of trying to predict which of our diabetes patients is most likely to end up in the emergency room with a severe hypoglycemia episode or diabetic ketoacidosis. And so if we apply some of these machine learning methods, then we might be able to stratify the population and predict for whom is that going to happen in the next month, for instance. I gave this talk to a wide audience in Vienna, and so I used some images to help get points across. So when some folks hear about machine learning, they think about artificial intelligence, or they think about machines taking action in the world. And in fact, machine learning is neither of these. Again, as Len has taught me, it's simply computation. It cannot take any action on its own. So in order to make it a useful tool, we really have to pair it with an ecosystem where humans are actually taking action based on the information in a reasonable time frame. So here's the project leadership from Cyft, from Joslin Diabetes Center. My colleague Susanna Patton is helping lead on intervention development here at Children's Mercy. Here's just a very schematic project roadmap. So the idea here is that the Joslin Diabetes Center is sharing data with Cyft and having interactions with Cyft on a regular basis. Children's Mercy is doing the same. We are having shared learning sessions, although Joslin and Children's Mercy are not sharing data with each other. We're learning from each other's experience interacting with Cyft as a data science company. And each of us over the course of this project will be predicting at least one health outcome and at least one financial outcome. And we've said repeatedly that if we predict only one, that probably we have not been successful, that we really are aiming to do more than that, but what we've committed to in the project is one of each. And so the model is really to build the predictive model using large bullets of historic data, to go through model validation, to couple that with a quality improvement project charter, and then to run plan, do, study, act cycles to implement the change and measure the outcome of the change. So the problem statement we decided to tackle first at Children's Mercy is, can we use machine learning to understand and reduce the percent of patients with large rises in hemoglobin A1C for the reasons that I mentioned earlier in the talk. Why is predicting the rate of A1C rise important? Well, if we take the case of hospital admissions, if I stratify a population by their rate of change in A1C, and I ask what happens over the course of 12 months or 24 months, then we can see that the rate of hospital admission is highest in the highest risk stratum for A1C rise. And so, this is measuring the rate of change over the prior 12 months or the prior 24 months, and then we can see what happens over the next 180 days or so. These outcomes are linked, right? Those who are having the highest rise of A1C are probably also experiencing some deterioration in their daily self-management behaviors, and that deterioration is now predicting their rate of hospital admission. So what we did at Children's Mercy to work with Cyft is we supplied 5 years of electronic health record data on our type 1 diabetes population. We delivered discrete electronic health record data. We delivered clinical documents, not only from diabetes care, but from other clinics. We delivered device data that we've been collecting on a pretty significant proportion of the population, not 100%, but a significant proportion of the population during that time period. And more recently developed patient-reported outcomes that we've integrated into our medical record. And now I'll just point out that we're more recently, since these data were collected, we're collecting in an ongoing way, for instance, depression screening results, anxiety screening results, disordered eating behavior screening results at the point of clinical contact. And so the opportunity to couple new enhanced data collection on the patient population to these predictive models is immense. So we started with about 2,760 patients with about 37,000 total A1C observations. We excluded A1C observations that were within 30-day intervals of each other, so that left us about 20,200 and about 2,200 unique patients. And then we decided to put some limits on the population. And this was the Cyft data scientists who did this. So they included patients who were 9 years or greater with an initial A1C of less than 12% and who had an interval of 70 to 110 days between their current A1C and the next A1C. And so that gave us about 9,650 cases of intervals from one A1C to the next to study. And then we incorporated device data that were available. And so we included data from the 2 weeks prior to the next visit, the 4 weeks prior, 6 weeks, and 8 weeks. And I believe, if I remember correctly, these were mutually exclusive windows. So we looked at each 2-week increment and asked whether those data were useful in in predictive model building. And so if we just use bivariate correlations and very simple statistical approaches and ask, okay, how does the prior A1C relate to the A1C change between this visit and the next visit? The maximum change that we can predict is a little over 0.7%. And so what that looks like in terms of the distribution of A1C changes is this. So if this is the distribution of raw A1C change values from this visit to the next visit. A linear model collapses that curve down to something that looks like this, where the right tail ends at about 0.7%. And if we apply machine learning and natural language processing, then we really add emphasis to this right tail, where we can now distinguish individuals who are at even higher risk for a higher rise in A1C. So the way the model training and validation occurred is we took all the available cases, divided them into 3 folds, and then Len's group, John and Jeff and others, created pairwise groupings of these folds to fit the model in 3 different pairwise groupings, and then used the 3rd fold to evaluate the model so that there was a 3-fold validation. A total of about 17,500 features were included. About 1,600 features were used in any of the 3 folds, or pairwise fold groupings, and about 305 features were used in all folds. So this is what the model distilled down to in terms of validated features. Len's group also evaluated the distribution of residuals and root mean square error as a measure of the precision of the models. And so the goal, of course, is to try to minimize this to create a more precise model. And so this graph here shows us what the root mean square error looks like for a model that uses just a bivariate correlation just with EHR data, and what a model using machine learning and natural language processing looks like, again, just with EHR data. And if we add the mean blood glucose and the last A1C to a statistical model, you can see that the root mean square error decreases. But again, using a machine learning approach with both of those sources of data, that the root mean square error is even lower than with a simple statistical model. And so these graphs give us a way to visualize the precision of the machine learning model. So in this case, if we follow the blue line just gives us a sense for what our precision would be if we perform random selection from the population. And on the x-axis here, we have the predicted rise in A1C, and on the y-axis, we have the precision. And so, for instance, if I want to predict people who are going to have a 1% or greater rise in A1C, you can see that I would be right about 15% of the time using a null model. But with the clinical model using just electronic health record data, I can get about 50%. And so we have a really significant increase compared to that. If we look at the count of predicted cases, again, you can see this sort of long tail to the right that approaches 0, but that actually has a significant number of cases if we blow that up, which we'll do in a moment to look at it in a more granular way. If I compare the null model to a model that, again, includes just a bivariate correlation, you can see that the null model is better than the simple statistical model, and the simple statistical model, remember, doesn't predict anything above about 0.74%. And so what I'm going to show you in the next slide is how many cases are here above 0.74%. And so if we blow that up, you can see that the numbers of cases at 0.8 and 0.9 and 1% and above are going to total in the few hundred, and these are really the highest risk cases for us. So what happens if we add device data to these predictive models? so if we look at data 8 weeks prior to their next visit where we're measuring A1C, you can see sort of what the precision looks like as we're trying to predict a higher rise in A1C. You can see that the data 8 weeks away from the next visit is not as precise as the data 2 weeks away from the subsequent visit. So as we approach that next visit, there's information value that may allow us to decide to escalate or pivot our intervention to try to make a difference in the outcome. And so it's not just the data that we have available today at our clinic visit and all the historic data that are of value. It's also the data that are being collected from devices between now and the next visit. And the closer we get to the next visit, the more we can make decisions about who we should pay attention to the most. And you can see that, again, you know, coming out here to predict about 0.9 or 1% rise, that we can get between about 65 and 70% precision if we add device data. So this is the data model for predicting a rise in A1C. So we're looking at a single case of A1C change from today to the next clinic visit. And we use unbounded clinical data, both discrete data and the full text of clinic notes. This is the population, and we're looking at an interval of 70 to 100 days, and we're including mutually exclusive device data windows here, and trying to enhance the predictive ability of the model. So you might imagine that we would run a model after this visit occurs and see who the highest risk patients are, and then run the model at one or more points here between now and the next visit to make some critical decisions about how to spend our time with this population once we've selected them. So I'm going to pivot there, and I'm going to also mention how our colleagues at the Joslin Diabetes Center have used this. So Children's Mercy started with predicting a health outcome. Joslin started with predicting a financial outcome. And so their problem statement was, can we use machine learning to understand and reduce clinic no-shows? And so one of the, and the picture of the cat here is simply, we don't know if somebody no-shows whether they've simply forgotten about it and they're still sleeping, or they're you know, hard at work and they forgot about it. So the common misconception is that machine learning is a sort of black box, but when used as part of a data-informed strategy, it's really quite the opposite. And I think this project from our colleagues at Joslin demonstrates that. So the data helped Sanj and his team understand the problem, and Len's team understand the problem at a more granular level. There are two separate but related issues: no-shows and short-term cancellations. Short-term cancellations were actually found to be 2.4 times more common than no-shows. And there's little overlap between the populations that no-show frequently and the population that has short-term cancellations. So that moves us away from a sort of one-size-fits-all understanding of the problem, and that we've really got two problems here. So the groups also have different risk patterns. So no-shows are somewhat habitual, and they can be well explained by past behavior. So just looking at the chances of a no-show in the future with 0 no-shows in the past, 1 or 2 or more, you can see this rapid rise in the risk of a future no-show. Short-term cancellations are less habitual, but they're not easily grouped, and the risk is harder to explain unless you use machine learning. And so here you can see that you know, you can get precision between 30 and 40% with simple logistic regression, but you can get a dramatically increased precision with machine learning to predict individuals who will be short-term cancellations on the clinic schedule. And I should mention, I don't recall exactly how the Joslin Group defined short-term cancellations, but I believe it's within 24 to 48 hours. Len, you or one of your colleagues might be able to clarify that. So what are the lessons from that? Well, the machine learning is really just a tool for learning, and we have to have a blueprint for using it, and there has to be skill on the data science side in applying these tools, and Len's group are really experts at that. That machine learning really requires people and processes and understanding to actually be a useful tool. That using this as a tool, data can make problems smaller, and that it can help us find the most actionable subset to steer interventions toward. And I think this is really important because one of the cost-effective care principles I think we need to follow here is that some of the interventions in our toolbox, you know, theoretically could help a broad proportion of the population, but they're very expensive and time-consuming to deploy. So one of the things we have to decide is how to deploy them in the most cost-effective way to get the most bang for our buck. So again, I just want to thank the project leadership. Sanj's team is setting up quality improvement project charters now. Susanna and Ryan McDonough at our center are helping me set these up along with several of our other team members, Kate Gibbs, David Williams, Dara Watkins, and others. You know, we've created a key driver diagram for trying to reduce the percent of patients with a rising A1C. We've got a list of key drivers, and then what we've done is we've tried to map interventions onto these key drivers. And so we moved from building a key driver diagram to trying to now perform an environmental scan of the literature and identify interventions that might move the needle on any of these drivers of a rising A1C. And Kate led us through a prioritization matrix and exercise. And so what we did is we brought a team of experts together and we said, okay, let's think about 4 or 5 interventions each for high-risk patients that we could sort of throw at the wall. And then let's think about whether they're high or low effort and high or low impact when the whole team reviews them all together. And so we came up with this matrix, and we found that in the upper left here are our quick wins, and you can see some themes. So having a defined follow-up plan for patients with high-risk factors, applying direct-to-consumer telemedicine, using technology. In this case, it said at diagnosis, but we think that, you know, sort of applying mobile apps that make it easier for patients to share data. So here it is, increased adoption of apps. But some of these things are both potentially impactful and require not so much effort. Some others may be impactful but require a lot of effort, and one that has actually switched in the last couple weeks, categories here, is peer coaching, so peer mentoring. So Children's Mercy actually now has a formal program, so we're going to be able to move peer mentoring from the upper right to the upper left because it's a lot more feasible in the last few weeks. And so going back to our model for improvement and what we're trying to accomplish, what we're doing right now is writing an intervention manual and a change package to put together with the predictive model so that in a short time frame we can actually be running the predictive models on live data in real time, and then we can be selecting patients in small tests of change at one clinic site or one clinic day a week, et cetera, to enroll in this alternate pathway of care. We think the alternate pathway of care that we're going to start with first is going to involve encouraging more frequent data sharing from devices coupled with direct-to-consumer telehealth using KidCare Anywhere, the American Well program, to create increased touch points for us. And then Sanj's team will be doing something similar on the business side, trying to reduce the number of short-term cancellations or to somehow otherwise reduce the impact of those cancellations on their bottom line. So just a brief acknowledgement to everybody on our internal team who's involved, and Len's team and Sanja's team and Denise Dalton, who's on the call in the Helmsley Charitable Trust. And then one last thing that I want to mention before I go is sort of where are we headed with using the device data. So one problem that you have to solve in order to use the device data in near real time to drive these models is you have to be able to get the device data in near real time. And so one of the things that we've done is we've stood up systems that we built over a year ago, but we've revised more recently and are working to stand back up on our clinical side that we call Portia, and that really allows us to take data from multiple data sources in the cloud to pass them through a sort of universal adapter or message broker and then pass them to subscribing services. And so you can imagine, for instance, if we're talking about data from diabetes devices, that we can reach out to those systems into which we're uploading devices in clinical care, bring them down, and then pass them to Cyft to put into the machine learning engines. And that's kind of all I'll say about that, except just to point out that it's data factories, a message broker, and subscribing services that make it up, and that we've recently revised the system so that a version of it now lives in Microsoft Azure. And this is just an example of how we're applying it to one particular project, but again, it's going to be important for this project as well. I'll stop there and ask if there are questions. You'll have to unmute yourself if you have a question.
Thanks for walking us through that, Mark. It looks really good.
Appreciate it, Mark. So Mark, you've probably seen we have an internal newsletter, so I'll be posting these slides on the internal newsletter to go out to the administration and stakeholders outside of the study team. And then I've also invited Sanj, to provide content and to share that at Joslin. And then we've got a couple of other venues this year where we're going to be sharing information about the project even as we're moving on to the next steps.
For the appointment analysis, so if I remember correctly, there were multiple thousands of appointments driving that data set?
Yes. So they also shared a rather large amount of data. I don't think, John or Jeff, you guys may know more than I do about how much data actually went into that model build.
I remember the Venn diagram had 2,000 over each, top 2,000.
2,000, yeah.
Actually, if you can hear me all right, that was just the top 2,000. That was part of an analysis to understand the overlap between those that short-term canceled and those that no-showed, which turned out to be two different phenomena and two different subpopulations of people.
Yeah, do you know how much data you started with, Len?
Yeah, I have Brian right here. Brian, how much data did we use? I know it's 2 years worth of data and all appointments, so it was pretty good numbers.
Hey, this is Brian. We had 26 months of data, and I think we were looking at around 180,000 appointments.
Oh, yeah. We, in a totally different domain, did an analysis on factors influencing no-shows and cancellations for spina bifida clinic, which we'd have multidisciplinary care groups lined up, and it has a significant impact on their staffing and scheduling when there's a no-show. But it was a very modest data set. So I think that's a something that has a lot of generalizable potential beyond diabetes.
Right. And I think from an institutional perspective, Mark, one of the things, you know, to take away from this is, of course, I'm interested in it for diabetes, but, you know, if we're trying to demonstrate that this is a cost-effective approach, we don't want it to just be a cost-effective approach for diabetes, right? There's an economy of scale, so if you can apply it to different clinical areas, of course, and different outcomes that you want to model in those clinical areas, then it's a win-win.
Yeah.
Other questions? So some of you were familiar with this because you helped me build the slides, and some of you are on the team that's been doing the work but may not have seen it all presented in this way before. And
Mark, how was this received when you presented it?
Oh, I think it was received very well. So we had I had a number of folks approach me, and Sanj was in the audience. So he, you know, I'm a little immune to what the audience is doing when I'm speaking, but he thought that there was a fair amount of excitement both during and after as well. I think this is really different. You know, at the ATTD, a lot of people are focused on how to use data to drive closed-loop technology and to drive insulin decision support. And what we presented was really quite different than what a lot of people are thinking about.
Okay, well, thanks for taking the lead and putting it out there for everybody. Really appreciate it. And you did a great job with it as far as I can tell.
Well, good. I appreciate that. So I'm hoping, you know, if anybody has any other questions, you know, now or later, certainly email those. You'll see the slides included in the next newsletter. And then, Mark, I'm looking for some help to try and disseminate this information in the administration. So anything you can do to help us out.
Maybe we should have you give we're bringing in people if you could give kind of the Reader's Digest 10-minute version to the Research Institute leadership, I think it'd be well received.
Yeah, perfect.